Now this is a mannequin skill. So let me pull up the skills page for you so you can see this. This is on page 110 of your skills book. So if you look at this, it tells us to provide Pericare to an incontinent patient. The female patient has been incontinent of urine and needs perineal care. The pad under the resident is wet, but the hospital gown and bedding is dry. Guys, this is a miracle. It never works this way. Normally, if you're doing Pericare, you're also changing the gown and the bedding as well. This is a long skill. It says someone with your level of experience will take about 17 minutes to do this skill. But it is done on a mannequin. So you're not going to be doing this on a real live person for the test. It'll be a mannequin, but you still want to talk to the mannequin as if she's a real person. That mannequin will be positioned in bed. Charting is not required. So if you scroll up here, you can see all of the different supplies, and there are a lot of supplies for this. Try to make it make sense for you. Gloves, of course, will be required because this is a bathing suit area. If we're going to be touching ooey gooey, if we're going to be touching skin normally covered by a bathing suit, and if we're going to be touching non-intact skin, we need gloves. So we need gloves for this one. So this is a washing skill. And we already know washing skills, right? We get water, we check it, we let them check it. Anything we wash, we rinse. Anything we rinse, we dry. Don't get the surface wet, so we're going to change that pad so we have a dry surface to clean on. If the patient's uncovered or undressed, we're going to use a privacy blanket. So we already know a lot of these rules. First, we need to talk about incontinence. So in your white skills book, if you turn to page 107, this is a lesson you need to read. I'm going to go over some of it, but not all of it. So you need to read page 107 and then 108 to truly understand what incontinence is and what it means for you regarding the patient. But the term incontinence means unable to hold bowel and or bladder. You can have bladder incontinence, you can have bowel incontinence, and you can have both. But just because you have one doesn't necessarily mean you have the other. They work on totally different systems. So in order to understand what incontinence is, I want to bring your attention to the graphic on page 107 right here, this graphic here. So if you're looking at this, you can see that a normal elimination system, you have two kidneys, you have tubes that lead from the kidneys down to a storage unit called a bladder, and then there's a tube that leads from the bladder to the outside world. That tube is called the urethra. There's a little valve at the bottom of the bladder at the entrance to the urethra that holds that bladder closed. And this allows you to go anywhere without wetting yourself all day long. So that valve at the bottom of your bladder is shut. Your kidneys filter blood 24 hours a day. They never ever stop. So your kidneys filter blood and it produces urine, drip, drip, drip down those tubes, and all those drips gather in the bladder. Okay, so kidneys filter blood, produce urine. Those drips of urine go down ureters and gather in the bladder. Over time, your bladder fills. Once your bladder is full, your brain says, hey, we got to go find a bathroom. You go to the bathroom, and then that valve at the bottom of your bladder opens, and that urine that's in the bladder is able to go out through the urethra into the toilet. When you're done, that valve closes back up, and now you're ready to go for several more hours. It's a great system. When somebody is incontinent, when we have an incontinent patient, that system still works. The kidneys still filter blood and produce urine, drip, drip, drip. Those drips still go down ureters into the bladder, drip, drip, drip. The thing that is broken here, the thing that doesn't work is the valve at the bottom of the bladder. It doesn't close. So all of those drips that go into the bladder, they just come right out. That means that an incontinent patient is going to be wet all the time. All the time, 24 hours a day. Drip, drip, drip. Now this is going to be affected by position too. When somebody turns over in bed, they're going to drip a little bit more. If they have pressure, like if they're sitting down or standing up, they're going to drip a little bit more. So this is positional as well. Position will affect it. But what we need to understand is an incontinent patient is going to be wet all the time. That's what incontinence is. Now, if you've got a patient who is dry, 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 really, really wet, you do not have an incontinent patient. That valve is working. That bladder is holding urine. That patient is not incontinent. Either you have incompetent staff members who are not taking the patient to the bathroom because it's too much work, or you have a patient with energy deficits that can't make it to the bathroom. But you do not have an incontinent patient. It's important that you understand that dynamic. If your patient is dry, 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 really, really wet, that valve is holding urine in the bladder. That is not an incontinent patient. Okay, what we can do is work on strategies to get the patient to the bathroom more often. Maybe we can use a bedside commode brought over to the side of the bed to transfer the patient onto. Maybe we can have scheduled toilet trips, you know, when the patient is up and getting ready to go to meals or something like that. But we've got strategies that we can work on there. No one wants to wet themselves. This is a dignity issue. So if we can find some strategies to help the patient maintain their dignity, that's the best route to go. But if the patient is truly incontinent and that valve doesn't work, then we have to figure out, what do we do with that? What do we do with that information? So if we have a patient who is truly incontinent and the valve is not holding urine in the bladder and the urine is just coming out drip, 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 we have to understand that adult urine is not like baby urine. Baby urine is very mild because babies are on a very controlled diet. They only, you know, drink breast milk or a specific formula. They're on, you know, maybe a mild rice cereal if we're just starting them on foods. But their baby urine, very mild, very alkaline, doesn't really affect the skin too much. So the urine is completely different. Adult urine, way more acidic. Way more acidic because the urine is affected, the acidity of the urine is affected by the foods we eat. It's affected on the amount of cell decay because as cells get broken down by the liver, it excretes acid, which goes into the urine. That's why it's uric acid. Adult urine, way different. Now, you don't want acid right up against the skin because it's going to eat into the skin. It'll burn it. So when we have a patient who is incontinent and wet all the time, drip, 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 then that means that we have to clean that patient's skin on a regular, routine schedule. So again, we're going to go right back to that every 2 hours around the clock. Remember, we learned that for Bedore Prevention. We're going to turn a patient who's immobile every 2 hours around the clock. Well, if the patient is immobile and incontinent, we're not just going to turn them, we're also going to do Pericare on them at the same time. So this is every 2 hours around the clock. At 2 a.m., you're waking them up. At 4 a.m., you're waking them up. At 6 a.m., yep, you're doing Pericare. Don't skip a session, you know, a cleaning session because you want the patient to be able to sleep through the night. That patient won't be able to sleep when they end up with huge sores and skin infections because the urine was allowed to lay on the skin for too long. When we have a patient who is incontinent, that urine itself, we have to control it somehow if the patient is out of bed, right? So if the patient is getting up and going to activities or going to the dining room for meals, they don't want to wet themselves. That's a dignity issue. So we usually use something called a Depends or an adult brief. We never ever call them adult diapers. Never use the term diaper with an adult. Patient can call it anything they want to, but we as medical professionals do not use the term diaper when it comes to adults. So if you have a patient who's incontinent and out of bed, they will have an adult brief or a depends on, and we're still going to clean them and change them every 2 hours around the clock. That does not change. But when they're in bed, that adult brief is not the best idea. And that's because adult briefs hold in body heat. Remember, they're plastic lined because they're waterproof. So they hold in body heat, they block out light, and they hold moisture right against the skin. So you end up with warm, dark, moist, like the worst environment that there can be. So when our patient is out of bed, we can't do much about that. Adult brief is indicated cleaned and changed every 2 hours around the clock, no matter what. But when they're in bed, if the care plan says leave them open to air, then that's what we're going to do. We're not going to have an adult brief on them when they're in bed. Now, some people insist on wanting an adult brief, and that's for their own security, and that's fine. Care plan will tell you who's who. Remember, always go back to that care plan. But if the care plan says open to air, that means that what we want is to lay the patient on an incontinence pad that's going to draw that urine away from the skin, allow light and air to circulate. It doesn't hold in body heat, so we minimize that potential for bacterial infections and skin issues. So when a patient is in bed, a lot of times they will be open to air on an incontinence pad, and that pad is just going to hold the urine. They still have to be cleaned and changed every 2 hours, but we're not holding the urine right up next to the skin and holding in body heat. But that pad is not going to be all that comfortable for the patient because the pad, the urine on the pad, is hitting room temperature air. Now, urine, when it comes out of the body, is about 101 degrees, roughly, because, our body is 98.6 degrees, almost 99 degrees. That's hot. But urine is actually hotter than that because it's made up where your furnace is in your body, right in your tummy area. So urine is usually about 101 degrees when it comes out of the body. Now that 101 degree urine hits 75 degree air, which means it's going to cool down really fast. So that pad that's under the patient is probably going to feel cold, wet, and maybe even a little slimy to the patient. So when we're doing Pericare, when we have a patient on a pad open to air, the first thing that patient's going to want to do is get a clean pad under them because that pad is just going to feel cold. So change the pad. But now we've got a wet bottom on a clean pad. So when we get the patient all cleaned up for Pericare, we're going to clean the front, and then we're also going to clean the back because that backside is laying in urine. Once we get the patient all cleaned up, we're going to change the pad again. So now we've got a clean backside on a clean pad for the next 2 hours. So when a patient is incontinent and in bed open to air, we're going to change the pad, clean the front, clean the back, change the pad again. And we'll do that every 2 hours around the clock. A lot of times in facilities, your patient's going to be on a bowel or bladder retraining program. And what this means is if we take the patient to the bathroom every 2 hours around the clock, if we're religious about it, right? We still have, if you've got an incontinent patient, you're cleaning them up every 2 hours around the clock. So you're still working with them every 2 hours around the clock. But if we are going to retrain the patient, which is way better for the patient in so many ways, but if we're going to help the patient regain control over their bladder, then we, in addition to cleaning them and changing them, we take them to the bathroom every 2 hours around the clock. So at 2 a.m., we're getting them up, we're getting them to the bathroom, we're getting them cleaned up and changed, and then back to bed. If you do this for 3 days consistently, every 2 hours around the clock, all shifts, get the patient up, get them to the bathroom, get them cleaned up, get them dressed. Every 2 hours. A lot of patients can actually regain control of that muscle at the base of their bladder and become continent again. Now, I do want to explain that continence or incontinence and stress incontinence are a little bit different. So incontinence means that valve doesn't work at all. Urine just falls out. Stress incontinence is something that happens to generally females. It can happen to both sexes, but often females, usually females that have given birth. And what happens is when you laugh or you cough or you sneeze or you engage in activity like jumping or running or lifting, a little bit of urine can leak out. Now, this is not true incontinence because you're holding urine the rest of the time. Stress incontinence is a little bit different, and it's because the muscles on the pelvic floor, when you're pregnant, those muscles get all stretched out. And then after we have baby, they don't always go back to what they were before baby. And we aren't always diligent about doing the exercises we need to get those muscles back in the right shape. So because those muscles are weakened, they don't really hold that valve closed all that well. So when we have any downward pressure like laughing or coughing or sneezing, because those muscles aren't holding that valve as tight as they could, some urine can leak out. That is not true incontinence. That's stress incontinence. It's very common with women who have given birth. So if you've got a patient who's a little bit wet after they cough or sneeze or laugh, don't label them as incontinent. It's two different things. Incontinence, true incontinence, means the patient can't control the urine at all, ever. It just flows right out. So you need to understand the difference between the two. But a question I get asked all the time is, well, if the patient is incontinent, why don't we just use a catheter with them? I mean, why can't we just, cut that incontinence right out by putting a catheter in? And the reason that you don't do that is because catheters carry a lot of risks. If bacteria is allowed to enter that catheter, it's a closed system, which means that there is nothing in the world standing between that bacteria and the patient's bladder. And along the way, that bacteria is going to multiply. So by the time that bacteria climbs up the catheter and jumps out in the patient's bladder, there are trillions of bacteria that invade that patient. So the patient goes from fine to really sick like that. I mean, super quick, because there's nothing to prevent that infection along the way, from proliferating. And we'll get to that a little bit more on Wednesday. But we don't use catheters unless there is a physical need for us to use a catheter. We don't use it for convenience. And that's what it would be. If we put a catheter in the patient because they were incontinent, that's just a convenience thing. If the urine is coming out, it doesn't need a catheter to make it come out. It's coming out just fine on its own. So cleaning the patient every 2 hours around the clock is a much better option. One of the things that you guys do need to know, though, is that in elderly patients, particularly incontinent patients or those with catheters, a lot of times the very first sign of a urinary tract infection is confusion. So, and this gets missed by CNAs all the time. Let's say we have Sally, and Sally's just a little bit pleasantly confused. She doesn't know what day it is. She doesn't know what time it is. She can't remember if she had lunch or not. But, she knows who she is. She knows who you are. She's just pleasantly confused. And then you go to work one day, and now all of a sudden, she is really confused. She has no idea where she is. She has no idea what she's doing. She has no idea who you are. She has no idea who she is. She's just really confused. You need to let the nurse know right away, because chances are she probably has a urinary tract infection. The very first sign of UTIs in the elderly is increased confusion. Now, the reason CNAs miss this quite a bit is because a lot of times CNAs think all old people are confused. I don't need to report that. She's just having a bad day. No, she may be having a huge bacterial infection that needs to be addressed right away. So any changes in the patient, especially any increase in confusion, needs to be relayed to the nurse immediately, okay? And that's something that most CNAs don't really put that together. So any change in confusion gets relayed to the nurse right away. Let me explain to you about the leaves method. That's what I'm talking about now. When we're washing a wet body opening, So this would be eyes, nose, mouth, genitals, rectal area, anywhere where stuff can get out of a patient or stuff can go into a patient. We have to use a certain a new washing technique, and that's called the leaves method. So this is just a plain regular square washcloth, right? If you fold it in half and then in half again, and you hold it not as a square, right? This is a square. This is how we normally look at it. Hold it as a diamond instead. And if you position it with the free edges at the top of the diamond shape, fold in the side pieces, you can use this area to clean something. So you can wipe one eye, you can wipe the genital area, you can wipe the rectal area. So you use this to wipe one area, but it's a one-way trip. So one wipe and that's it. You don't go back. And then you're going to fold that over, which traps the contamination underneath. Now I have a new cleaning surface here. So I can use that to clean, fold that over, give me another new cleaning surface. I use that to clean, fold that over, gives me a new cleaning surface. I use that to clean. And if I needed a fifth surface, I could fold that over and use this area. Remember, whatever you wash, you rinse the exact same way. So we don't need to learn anything new here. We're going to use the same leaves method, just no soap. Whatever you rinse, you dry. So there's not a whole lot here that's unusual or different. It's the same washing rules that we've learned up till now. We're going to use the same privacy blanket that we've learned up until now. We also learned clean rolls toward me, dirty rolls away. So when we're going to put a chucks under the patient, we're going to roll it toward us, just like we did with bedpan. So if you notice, this skill has a ton of other pieces of other skills in it. But there's not a whole lot of new stuff that you have to learn other than the leaves method. And anytime we clean a female patient, we're always going to start at the top of the peri area and go down, one-way trip. Never go down and then back up. So it start at the top, go down, move away, fold over. When we're doing Pericare, we're going to go down the middle, side, side, and then the crease between the leg and the groin, that little crease, we're going to clean that, and then we'll clean the one over here. So we're going to need 5 leaves for this particular skill. Middle, side, side, skin fold, skin fold. Then we'll turn the patient over and we're going to clean their backside. We're going to go up the central crease, fold over. We're going to clean one buttocks cheek, fold over, clean the other buttocks cheek, fold over, and then once more up the center crease, because that's where the urine is going to run. It's kind of like a riverbed. That's where the urine will run, and that'll get it nice and clean. On the front, you go top to bottom. On the back, you go bottom to top. So it's just kind of a U, always away from the urethra. Question I get asked a lot on this is, what about male pericare? On page 111 here, I have a whole section on male pericare, and you'll need to read that because that's information you may need for the written exam. Male pericare is, there are some special considerations there, so make sure you read that section. But for the test, this is going to be on female pericare because the way we wipe is super important. Female urethras, that tube that goes from the bladder to the outside world, is only about as long as your pinky, and that's not very far for bacteria to travel. Now, every bacteria in the world is trying to find a bladder to get into. It's the ideal breeding environment. It's warm, it's dark, it's moist, but even better, it's got an all-you-can-eat buffet and an open bar. It's got enzymes and proteins that make procreation much, much easier for bacteria. And something you may not realize is that bacteria don't need little boy bacteria and little girl bacteria to have baby bacteria. It doesn't work that way. All a bacteria needs is the right environment and the right proteins, and they actually zip themselves in half and create a clone. So now 1 turns into 2. 2 turns into 4. So it's very easy for one bacteria to become a whole colony of bacteria if the conditions are right. So when we're doing female pericare, the way we wipe counts. We don't want to bring a whole ton of bacteria from the rectal area up to the urethra where your white blood cells aren't going to be able to catch all of them, and some of them are going to make it into the bladder, and they will cause a UTI. So the way we wipe is super important in females. With males, not as important. You're just going to start at the top, clean down the shaft, clean the scrotum, rinse and dry. But if foreskin is involved, you do have to retract the foreskin to clean underneath and then put it back where you found it. But go ahead and read that section on page 111.